Good evening, everyone. I'm Kevin Rudd, and I'm the President and CEO of the Asia Society. At the Asia Society, we hear almost daily accounts from friends and colleagues in India who've been struggling to cope with the threats of the current scourge. On behalf of our global centres around the world, management and our board, I extend our most sincere support and solidarity and our best wishes to everyone in the country. The Indian medical professionals, emergency care workers and local administrative bodies have shown exemplary resilience, fortitude and dedication, and they have our deepest admiration. These are extremely challenging times for India and all of South Asia, a moment that demands a response from all of us in India and across the international community as well, to ensure that the country and the region will emerge stronger from this most critical situation. At the Asia Society, we take our role as a convener and a catalyst at such moments deeply seriously. It's why we bring a global audience program like these. It's why we are actively working to leverage our relations with governments, with diplomatic missions, to help mobilise resources for India. And it is why at our website, you will find links to well-vetted relief and medical organisations in India and suggestions as to how to help. For example, how to help mobilise resources and quell the severity of the situation. Since the onset of the pandemic in March last year, the Asia Society India Centre, located in Mumbai, has successfully hosted leading global public health experts and specialists to speak to our audiences about the virus, about public health best practices, about vaccines, and of course the ways to strengthen the healthcare system in India. Our program today is timely as it aims to provide critical observations and insights from what is happening on the ground and to counter and dispel misinformation about various aspects of India's second wave, ranging from vaccines to emergency use medicines and, of course, other dimensions as well. One of our speakers today, who you'll meet in a moment, Dr. Satchit Balsari, is a member of our Asia 21 Young Leaders Network, a network whose India chapter is playing an important role during the crisis. Once again, I would like to wish all of you the very best, and I hope you will find the discussion informative and, most importantly, useful. Our thoughts and our solidarity extend to all of you at this most difficult time.
Thank you, Kevin, for your very kind note of support and encouragement. Good evening, and many thanks to all of you who've joined us this evening for this seminal discussion. My name is Inakshi Sopti, and I'm the Chief Executive Officer of the Asia Society India Centre. I'm delighted to see members, patrons, and friends from across the world join us this evening. For those of you who are joining us for the first time, the Asia Society is a leading educational organization dedicated to building awareness about policy, business, education, and arts from across Asia on a global stage. Inaugurated in 2006 by Prime Minister Manmohan Singh, the India Centre has hosted over 800 events, establishing itself as an important forum for the discussion of regional and global affairs. India's second wave of the COVID-19 pandemic has been a grim reminder of the limitations in our public health delivery, health communication channels, and lack of preparedness. We've shown immense resilience to this devastating crisis as we witnessed several citizen-led initiatives reaching out to people in need of immediate medical help. It's also heartening to see international support in these testing times, an important testament of global solidarity and togetherness. However, going forward, what areas should receive immediate attention in order to control the situation in the upcoming 6 months? Considering the limitations of health infrastructure in rural India, what best efforts can be put into to ensure that the situation does not take a massive toll on life? Additionally, what measures can be implemented to prevent the spread of misinformation about the virus and its treatment procedures? Our program this evening will discuss all these aspects in detail. As a continuation to this, we will be joined by renowned pulmonologist Dr. Zarir Udvadia and Chapel Mehra next week to better understand India's vaccination drive in the context of new variants and its bearing on combating future surges. We have the honor of hosting a distinguished panel this evening. Dr. Ambarish Satwik is a Delhi-based vascular and endovascular surgeon and writer. He's director of the Vascular Cath Lab at Sir Gangaram Hospital and professor of vascular surgery at GRIP MER. Dr. Satwik is the author of the critically acclaimed novel Perineum, Nether Parts of the Empire. Polly Roy is a professor of virology at the London School of Hygiene and Tropical Medicine, specializing in molecular biology of RNA viruses. She's the leading exponent of the structure, genetic organization, and immunology of double-stranded RNA viruses with segmented genomes. Dr. Satchit Balsari is assistant professor in emergency medicine at Harvard Medical School and Beth Israel Deaconess Medical Center, and in global health and population at the Harvard T.H. Chan School of Public Health. Awarded the Asia 21 Fellowship in 2010 by Asia Society, he's faculty at the Harvard FXB Center for Health and Human Rights, where his research has contributed to advocacy on behalf of vulnerable populations affected by disasters and humanitarian crises. Govindraj Ethiraj, our moderator this evening, is a television and print journalist who's reported and written on Indian business for over 25 years. He's a media executive and entrepreneur whose public interest journalism ventures focus on safeguarding the transparency, accuracy, and integrity of news reporting. He's the founder of various independent journalism initiatives such as Boom, India Spend, and Fact Checker. We are very grateful to our outreach partners this evening, the India Center of the Harvard T.H. Chan School of Public Health. And a bit of housekeeping before we proceed. All those who are joining us on Zoom, please leave your questions in the Q&A box. For our audiences on Facebook, please drop them in the comment section. And with that, Govind, over to you.
Thank you very much, Inakshi and the Asia Society team for inviting me. It's a pleasure indeed to be part of this very, very important and timely panel and focus, which is how do we survive the surge and how should we navigate through the second wave of COVID-19. So the format that we're going to follow is as follows. In moments, I'm going to hand over to our speakers. They will speak for about 5 or 6 minutes each on this subject from their vantage point or their vantage points, which are quite different, as you will see. The idea is to then have a conversation picking up on some of the themes that they've raised, the questions that I may have, and of course, the questions that you have that I'm sure will come flying fast and furious. So on that note, I'm going to hand over and hopefully with an emphasis maybe on one is what is it that we can take away from what we are seeing today, and secondly, what is it that we can learn and implement, if so, for the third wave, which seems inevitable. As we know now that the number of cases, COVID-19 cases that are known are lowering. They are coming down in many parts of the country now. The last number that we have for Monday is 263,000 cases and 4,339 deaths. There is a larger problem, which I also hope that we will discuss later on, which is that of data. It is quite clear and evident now that the number of deaths that is put out officially has no bearing almost whatsoever with the number of real deaths that we are seeing across the country. This has profound implications for those who are trying to understand and study this disease and its spread, and therefore create or craft a response, particularly at a public health perspective. So those are some of the issues that we will talk about, apart from, of course, the medical and the other issues that frontline doctors are facing and their lessons in the second wave. So on that note, thank you very much once again, Asia Society. And let me hand over first to Professor Polly Roy. It's over to you.
Thank you very much. And thank you for giving me the opportunity to talk today. So the current situation, what I see in India is clearly the result of having considered that the first wave is over, when in fact the virus was continuing to circulate widely in the population. And I'm absolutely convinced about that. This has been amplified by various religious, political, and cultural gatherings, which were ill-advised, and infection has now reached in a problematic level. The only way infection currently can be prevented is either physically, that is by distancing from an infected individual, or immunologically, that is by having sufficient antibodies to prevent the virus taking hold of the body. This translates into strict social distancing and mask wearing measure, and vaccination, of course, as soon as possible. This is a long term, is the vaccination is the most important aspect for this virus spread. While vaccination has begun, that we know that, it is evident from the numbers that it cannot reach the majority of the population in India very well until probably next year, as I can see. And until that time, the social distancing of some sort must remain in place. That is the vital thing right now. You have to understand virus is spread by aerosol, and the mask that people wear, often any country, not covering their nose, they take them off from the nose, which is the vital route of the virus entry, really. And so while the vaccination has begun, it is evident that from the numbers that it cannot reach the majority of the population. This is the vital thing, that we remain absolutely vigilant about this and make strict rules about that. Recently, hope has been placed, as we heard already, some of the virus is going down. And there are also 2 or 3 types of vaccine India has it, and I'm very, very optimistic about that we will have enough vaccine probably to cover everybody eventually in India. But also there are newly licensed drugs. People are talking that we can discuss later on. But it is also noteworthy, all the people thought these drugs are good and might help, but they're very little clinical setting data available still for most of the drugs they're talking about. WHO already now have decided some of the, they have tried some of the antiviral drugs, but this is almost impossible because host and virus interaction is so specific. They have to have particular time, and it has to be early, very early in the infection to use those drugs. But the other way to do it, some targeting the immune system, and that's what they're going to try. Some of the drugs they will retry again. But it is vital not to get too excited about the drug until we have large-scale people are tested, independent, not the people who have developed, independently has to be tested. Because in the long run, that could be dangerous. Things are always around, but we think it will work, but may not. So no one should believe in rapid cures before they are proven, and social distancing and vaccinations need to remain at the top of the priority for protection for this virus, that for the foreseeable future at least. So I think I will stop here.
Okay, thank you. Professor, a quick question, and this was posed to me when I shared the details of this evening's conference. You know, if assume we had not done anything, okay, so assume we had not done the lockdowns, assume we had not responded at all, how long would a virus like this take to burn through a population? Would it be the same time? I mean, I'm not talking about mortality. Obviously, there will be mortality, but would it be the same time? Would it be longer? Would it be less time?
So virus will always look for a good live cells. That means good body to get into it. Virus has no life without the body, human body or the animal or whatever. So virus is just a chemical constituent. You know, it's a protein, nucleic acid, lipid. That's it, nothing else there. It is only live when they have an opportunity to get into you. So if you're in dense population, if you have the infection already, but you don't know about it, because it's also a lot of people are asymptomatic, and you go to your close friend's house, and just the aerosol will distribute the virus from you, even though you don't know that, you know nothing about it. So you cannot predict, just cannot predict about these viruses. But we are assuming that most population will be vaccinated slowly, or you're doing fast now. So in our country here, very fast now, everybody trying, but people have to understand vaccines are the only way to go forward, really. And then we can only predict what will happen, herd immunity or whatever. Not enough people there to infect, and then they will disappear. More people there, they will infect continuously. And you have to understand, in your own body, you have so many cells. As it transmit one cell to another cell, is changing and taking more advantages that position. So virus doesn't really going to disappear until we do something about it. There is a war going on between us and the virus, and we have to take care of that.
Right.
And we have to win, of course. And then we will win, because particularly biological science is so advanced and we can do very quickly. I'm sure that will go, but unless the country or your little provinces and states or every village is taking care of it, you cannot predict. Even if 2 persons are already had the virus, didn't take vaccine, they go through somewhere, they will take the whole country off again, So that's what depends on how people change their behavior.
Right. Okay. Right. Dr. Satwik, it's over to you.
Thank you. Thank you for having me on this panel. I'm not entirely sure I have a vantage point. I seem to be the embodiment of that meme that was circulating, that please wear your mask, otherwise you'll have a vascular surgeon treating your pneumonia. So that is precisely what is happening. But what have we learned from the second wave? I'm privy to some information, a couple of papers that are going to go into print in the very near future, and I can share some of the information with you. The first thing is that, when samples were collected this time around in the second wave, the RT-PCR samples, the cycle threshold values, the CT values that you evaluate, were much lower than what they were the last time around in the first wave. Now, cycle threshold values are inversely related to the viral load. So if you have low cycle threshold values, it means that the viral load in your nose and your throat at the time of testing is pretty high. At the time of testing, it has no bearing on severity of disease or outcome, but it simply means that the viral load in your nose and mouth at the time of testing was pretty high. So the cycle threshold values in the second wave were much, much lower than what they were in the first wave. Secondly, the B167 variant with its sublineages, one of the mutations that has been identified seems to be enabling the virus to form what is known as a syncytium, which means that when the virus is attacking the human cell, so it's trying to invade one cell of the host, but it's also simultaneously making the surrounding normal cells fuse and automatically attacking a cluster of cells when it is in fact attacking just one, which means this will have implications for virulence. It might have implications for severity of disease, but it will also have implications for transmissibility and for escalation of symptoms. So what we could extrapolate is that you have possibly a mortifyingly sinister virus this time around. It is a new virus altogether, and therefore it's a new epidemic, which is far, far more transmissible as a variant than the ancestral SARS-CoV-2, the first time, the wild strain of the virus. And therefore, these low CT values mean that there's enough virus in the nose and the throat of the infected individual to be passed on and aerosolized even when they're speaking. All right, now this is very important to understand, which means, and when you add to this the piece of information that perhaps an individual is most contagious one day prior to developing symptoms, because when someone is symptomatic, they're obviously masking themselves and staying away and are being sequestered. But when you're not symptomatic, you're mingling with people, interacting with people. And when you've got such a transmissible variant with high viral loads in the nasal cavity and the throat, you're practically aerosolizing the virus when you're speaking. So this is the time to double down on non-pharmacological interventions. You need, and this is absolutely important because what we've seen this time around is excessive intramural spread amongst households. So the last time around, when we had one member of the family getting infected, there was about a 20% chance or less of intramural spread about the other members of the household getting infected. This time around, it's much, much higher. You're getting to see perhaps entire families that are infected. And therefore, these three sublineages of the mutant variant that we're dealing with is not just India's problem. I think this is going to be the world's problem. In the UK, you're seeing some of the results from the genome sequencing. You're seeing that almost 50 to 20% of all sequenced viruses are now of the B167 strain. This is the point when it takes off. So this is now the world's problem. It's not just India's problem. That's first. Secondly, I think something we have learned is that there is a finite capacity for tertiary hospitals to augment their infrastructure and their capacity. You can't expect them to overnight ramp up infrastructure or augment capacity, because that is going to affect outcomes. So let's say you suddenly ask a hospital to convert 80% of its beds to oxygen supplemented beds and rapidly escalate and augment the number of ICU beds, you're going to find, your outcomes are going to suffer because you don't have the human resources to take care of these critically ill patients. You need a certain kind of expertise to take care of severe COVID. Where you're going to get that from? You need round the clock, very skilled nursing care to take care of this. Where are you going to get that from? And at the same time, your consumables are going to be stressed, as we saw what happened with our ability to convey liquid oxygen to most of these tertiary capacities. How Mumbai fared differently was perhaps because of the jumbo facilities that it installed well before the second wave hit Mumbai. And these jumbo facilities weren't COVID care facilities. They were converted into ICU facilities with their own ability to manage critically ill patients, their own path labs and all of that, so that most of the tertiary hospitals were not congested and you could achieve uniformly better outcomes in a metropolitan area. So that's the other. And thirdly, I think we have to perhaps stress on a different format of testing, particularly in rural India or even in urban India when we're going to open up. And that, in my view, is going to be provided by rapid antigen testing, which is a quick format for testing, which can provide you results within 15 minutes. And it's an excellent test to diagnose infectiousness and the ability of an individual to infect others, rather than being a gold standard of infection in a particular individual. And I'm happy to talk about that later if there are any questions.
Okay, thank you very much. So you're the only Delhi representative here, as I can see. Just a quick question. I mean, if you would, if I were to ask you like any pesky news anchor, what's the update today? And to what extent, when you look back, could the problem have been resolved if we had the oxygen? Or to what extent was it an oxygen problem and not a COVID problem?
So it was what we saw was a gapingly and glaringly revealed, our lack of preparedness for this. And it probably hit us because we couldn't figure out when we were on the exponential arm of the growth curve, because it happened very rapidly. My sense is that I don't think we could have reacted very differently had we not prepared ourselves anterior to the episode. I think when we were in the middle of it, the only thing to do was kind of ride the storm or ride the tiger. But you have to prepare for this in advance, and which is why I think transparency with data is absolutely important, because that will allow you to allocate resources in the future. If you're suppressing data, you can never predict what's going to happen next.
Okay, thank you. Dr. Balsari, it's over to you.
Thank you, Govind. I'm going to try to answer your question, what is the takeaway and sort of what do we learn for the third wave, and build on what here we just heard. All important points that I'll try to not echo. We have been talking about the impact of the virus on Indian society. I think in order to prepare for the third wave, it is also important to acknowledge the impact of Indian society on the pandemic itself. How the people of India have dealt with it, how the state has dealt with it, and how healthcare providers have dealt with it. Dr. Roy did speak about the challenges in behavior modification throughout. Masking has been a challenge, and no attention has been paid to it. Professor Mushfiq Mubarak from Yale has demonstrated through his study in Bangladesh with over 300,000 people that the journey from asking people to mask up to actually getting a critical, epidemiologically significant number of people to correctly wear the mask, as Dr. Roy said, covering your nose and mouth, is a Herculean task. And there have been little to no investments in doing that, especially when you sort of consider the variety of societies that live in India. The state, Dr. Satwik just brought up the issue about data transparency. This cannot be underscored enough. The state's relationship with science has been tenuous at best throughout this pandemic. The data that have been released or in several states been suppressed, right? So you ask people not to test instead of assuming that all mortality or all excess mortality might be COVID. You want to minimize COVID deaths as if it is some bizarre badge of honor in the middle of a global pandemic, has led to extraordinarily misinformed decision-making. The state does not have the capacity, it just doesn't, especially at the local contextual level, to either analyze this data to act upon it. And instead of opening its arms wide and allowing the academic community, even domestically, there is enough expertise in India to help analyze this data. We've constantly shirked away and continue to do so from allowing data to inform the science to drive the policy response. This led, without the right kind of expertise at the table, an impotent contact tracing app, which we should have instead augmented significantly with boots on the ground, a luxury that we have in India. We had a baseless color coding system of locking populations ad hoc in and out based on really poor data that was even more poorly understood by the policymakers. And we just cannot afford to continue down this path between the second and third wave. The providers in India have been at the front lines, and sort of the sacrifice and the valor that all of us have seen in our communities and our WhatsApp groups has been exceptional. And yet they have also contributed significantly, likely both to morbidity and mortality in India. This Indian exceptionalism about this is how we do it in India, you do it differently in the US or UK, is reckless. Human biology is the same. And this eminence-based medicine over evidence-based medicine has resulted in this pandemic of steroid usage, where the timing is wrong, the dose is wrong, the indication is wrong, a plethora of antibiotics that continue to be peddled by eminent academic institutions and state agencies, and even distributed to populations, have led to all kinds of immune compromise that we're just beginning to see. We don't know where this mucormycosis is coming from. Is it all these antibiotics that have probably driven down the immunity combined with the reckless steroid usage, with sort of undiagnosed hyperglycemia in the community? What we needed is very, very simple epidemiological data to help us tease through this mess that we have created. So going forward, I think if there is one takeaway, it is the need to adhere to science, to listen to the scientists. You cannot have consulting companies on these decision boards, drawing up protocols for triaging and locking down and unlocking. We have to turn to the epidemiologists, the virologists, the clinicians at the front lines, as the National Task Force is reflecting, as some of these task force in Bombay have shown. I would urge policymakers and community response organizations to get the right kind of experts on board.
Okay. As I've been interviewing experts like you over the last year, this point has come through many times that we need to engage with women and men of science and form task forces that are diverse, comprising all kinds of representation, from obviously public health experts to epidemiologists to subject specialists and so on. So now that's not happened. I don't know, and you've mentioned that yourself, that even if we were to belatedly bring together more effective task forces without judicial intervention, whether we will actually act on it in the manner that it should be acted upon. What happens then?
I would say that there is a lot of movement on the ground to get this right. The latest laudable sort of intervention that'll have some national import are the CMC Velour simplified guidelines for treating COVID-19. Demystifying all of this and saying you have mild cases, stay at home, monitor yourself. You have moderate cases, let's get you the right kind of oxygen or the right kind of steroid if indicated, right? And protocols. And that's a significant contribution to the clinical noise to signal ratio that both patients and providers are experiencing. Over the last week, several large community-based organizations, right, like the large ones like JSS, BHS, Seva Mandir, Healing Fields, RCRC, have come together to basically recognize that rural India is going to be a manifold challenge compared to what we've seen in urban India, and collaborated with scientists across the world, with several sharp clinicians from India at the forefront of this response to band together to form what's called the Community Science Alliance. Swast is coordinating it as a secretariat. And essentially, these are all organizations that are committing to a science-based response, saying, let's figure out how do we take these simple measures that we know all the way from vaccine to appropriate treatment to vaccination, and come at our organizations, our providers, and our patients to a sound response. And I think when society leaves, when state leaves a vacuum, society has to step up. I think that is all we have between now and hopefully what will not be a third wave.
Okay. Professor Roy, I'm going to come to you on the virus itself. Dr. Satwik, this is a larger question, but there are three medicines or three names that have now become very, commonly used. There's ivermectin, there's remdesivir, and there is the use of plasma. Plasma now has been officially removed from the list of suggested treatments by the Indian Council of Medical Research. Doctors I've interviewed, even until recently, I've posed the same question. Are we fundamentally different as Indians? Are we different? Is the health ecosystem that we live in different? Therefore, should we be prescribed different medicines? So the answer seems to be that we are not. But yet the policy response, if I were to call that a policy response in terms of framing protocols, seems to be so far behind in time and space. And how do we even begin to address that?
So I don't think this is a policy matter. I mean, most physicians tend to have this maverick streak in them to kind of try and treat COVID in the manner they deem appropriate. Is that on account of the anxiety levels that are prevalent, patients are particularly anxious when they're not prescribed anything, when they're suffering from COVID. And this has to be addressed. This is not, the response to this shouldn't be your set of medicines that don't make any sense or a set of investigations, because that is going to put pressure and stress on the system. For instance, even inflammatory markers. I mean, there's no point in getting inflammatory markers done for cases of mild COVID every third day. We were at a point when laboratories in Delhi had run out of kits for, interleukin-6 and D-dimers and all of this. I mean, there's absolutely no indication for getting this done in cases of mild COVID. Similarly, I think when you've got all evidence that is against antivirals, particularly in the late phase of disease, it doesn't make sense for you to prescribe these antivirals. And then you've got patients, attendants, and relatives scampering around and scrounging for these medicines which get on the black market. So I don't think policy has anything to do with this, but you should definitely try and rationalize treatment. What is more important, in my sense, even telemedicine is a great, could be a great source of succor for many households, because all that is required is a surveillance a remote surveillance of the dwelling in which the patient is being confined as a part of home isolation, and figure out what would be a safe manner for primary caregivers to take care of the patient. Perhaps just a handful of tight-fitting N95 masks that are supplied to the family members would go a long way in addressing this issue and preventing transmission. I mean, there's wide-ranging consensus that 80% of cases of COVID are going to be mild, who will not require any treatment because this is a self-limiting viral illness.
Right. But let me, if I can press that, I mean, and not to pin you down because you're not the person to pin down. You're right that, that there is huge amount of patient pressure, and patients want to be prescribed something because, among other things, their cousins or their family members or friends have been prescribed something, or the feeling, as you said, that I'm going away empty-handed, and how do I fight this? And maybe, maybe cases are so acute that doctors also feel pressured. So there's no blame on doctors, but the fact is that the system takes a long time to respond and say that, okay, it's only now that we are saying that plasma doesn't work. It's only now that we're saying remdesivir may not be the best thing to do.
I don't think so. I think, we had this information possibly towards the end of last year. The convalescent plasma wasn't helping. In fact, the Solidarity trial established that remdesivir wasn't making any great difference in outcomes or difference in mortality, according any kind of mortality benefit or anything else. So we were armed with this information, but I think it's just perhaps it's temperamental. We tend to feel that you need to be filled in a prescription if you're dealing with a potentially life-threatening illness in the middle of a pandemic. It's just every person's consideration of their own sense of mortality, which is creating this panic, I think.
Okay, Dr. Balsari, do you want to come in here? I mean, do different countries or societies react differently, since you have spoken about behavior and culture?
I think it is a medical society here that has reacted simultaneously extremely bravely and putting their lives on the line when we didn't have the right kind of equipment or the infrastructure to practice in this kind of a high-risk environment, especially early on where we didn't know, it was droplet, it was aerosol, surfaces, not surfaces, etc. Right? There was hardly a physician that was on the front line that said, I'm not going to go to work. And yet they have behaved very irresponsibly, right? We've known all this for a while. This kind of experimentation is not tolerated in any society, in any medical society where there is sort of a little bit more regulation and oversight. This isn't a new problem. I think as all stressors, it brings to light the gaps and the weaknesses that we've had. We've been talking about India's contribution to antibiotic resistance globally for decades now, right? I mean, the next panel is with Dr. Advaria, who's significant body of work on tuberculosis comes from that. I mean, all of that has come home to roost.
Okay. Professor Roy, let me come to you. So the B1617, as Dr. Satwik described, is really almost like a new virus. And explain to us why this is so different and so deadly. And what does this portend for the future? I mean, how do we improve our understanding, even as lay people, of the way viruses mutate, the way they travel, and the way they can change in time? And I know that to some extent you've answered this question earlier, whether can transmission stop? And as you said, even if there are people in an entire country, it will soon spread very fast. But how do we understand this virus better, or improve our understanding of this or future viruses?
It's changing all the time. This is their way. They make error. And that errors doesn't mean they are always making bad virus or good virus. Nothing to do that may not have any effect at all in the virus outcome of infections or disease, okay? So in this case, 617, and also you have 618, I think, in West Bengal. So 617 is actually change one residue extra, which is from leucine to arginine. And I think that leucine to arginine, another one was glutamic acid to glutamic acid to glutamate. And what happened that the structures of the amino acid is quite changed, particularly with arginine, which is a very long and flexible in a way and can really interact with the receptor better, probably. But doesn't mean the transmissibility is better or disease is going to be more severe. One mutation cannot do, one or two mutation cannot make it different really much, because the whole spike protein and also in the physiogenic area, S1, S2 both, they are, and also N-terminus and C-terminus they have. The N-terminus particularly have some residues that are important for neutralization for antibody, okay? So, and the physiogenic part, if it changes, bad, of course. I think there's a P80 something that one is near to the spike fusioning, the furin activity. So these drastic changes may sometimes make a problem. However, if virus wants to survive properly, there's other area will mutate and compensate that and make it better. So the whole idea for virus is not to kill the cells quickly. They don't want to kill it. They want to survive, multiply fast. They want to multiply fast. If they kill, they cannot multiply. So they have to multiply fast. So I don't think the vaccine that we have now, the Wuhan strain, will still work against this, probably a little bit less than neutralizing antibody. The vast amount of neutralizing antibody is actually developed by the vaccines. So they're not going to all disappear, and they will still protect some, and they may actually, the mutation may again revert back again to adapt better. So you cannot really predict that way. Also, I don't completely believe that to change a virus completely, say from SARS-1 to SARS-2, many changes happen, many changes. That also those changes have to be accommodated by the virus genome such that they can make all the proteins properly as well. So most of them discarded because they cannot make any more. They're shifting the coding regions or whatever. So I think that we have to be a little bit less about the variant because it is not going to change that fast, and it is not going to have that much problem until it severely changes a lot. So we still, I consider all the vaccines that people have developed, different vaccines based on spike protein, and spike is the major contributors of the antibody. And then, for instance, the T cells is not going to be influenced much probably. So there, those protections still remains. So it is not that that thing that virus, because otherwise many people will die very fast. No, that's not possible actually. May transmit a little bit faster, but it will also go down different ways because, as I said, because transmission within the body, they're making changing, and virus wants to survive. They're not going to change a lot because then they have a different problem. So right. I think this mutant, I mean, I don't know because he's the doctors, he see the symptoms, but as a virologist, I know it is not actually possible to have one or two sites mutation makes very severe as far as disease concerned. But what is important may be transmissible more because the other virus is already old gone in a way. So they take over, not necessarily because this is the new virus. Yes, the new virus, they will take over. That is the circulating now, you know. So more circulate, more is going to circulate. So transmit. So I think that we are, as a virologist, I'm very optimistic in that respect that we can control, definitely, with the vaccine. And vaccines is so good these days. We can change and chop very easily and make the new type of vaccine to make it more better control the variant. But how many times you can change, right? So you have to make vaccines such that will control all this whole lot of variant easily, at least 80%. Control, so right. That will be fine already. That's the way I see it.
Okay.
Thank you.
I'm reminded of an interview I did with Professor Jeremy Camel, who's also a virologist based in the United States. And he said that, the 1617 is not going to drill a hole into your mask as long as it's an N95 mask. So maybe that's one way of looking at it. Okay. So there are lots of questions coming. And before Dr. Satwik, do you have a interpretation of what Professor Roy said? I mean, do you want to convey it any differently? I mean,
no, I think it's quite clear that that almost all vaccines are able to generate neutralizing antibodies against the wild strain of SARS-CoV-2. This is the original sort of grandmother virus that we were afflicted with. Now, there have been numerous studies which have been published and which are in the process of being published, which are showing a twofold, threefold, sixfold, sometimes even tenfold reduction in sensitivity of neutralizing antibodies to these variants. So in fact, the institution where I work, Sir Gangaram Hospital, we had a series of breakthrough infections and we quickly got them sampled and sequenced. And some of these were actually tested against banked Pfizer serum. And double vaccinated vaccinated serum, and found, not me, this was a collaborative study between Cambridge and some of our sequencing labs in India. And this is again going to go into print, but I can reveal that, there was a 3 to 6-fold reduction in sensitivity of the neutralizing antibodies. What that means is that there is definitely a dampened response to, that will be generated. Whether it will be enough to prevent us from getting infected is one question. But from the evidence that we are seeing, at least anecdotally, in India, and at least in my city, it is clear that most vaccinated individuals, irrespective of what vaccine they've received, are not ending up with severe disease or dying. So there's a great deal of protection against severe COVID and death due to the vaccine, but there are numerous cases of breakthrough infections, and therefore we need real-world effectiveness studies of vaccines, and I don't see that happening. We need data on the real-world effectiveness. There's no other way we're going to get an answer to this question.
Okay, so I'm going to start taking questions. Yeah, go ahead, Professor Roy.
About this Pfizer vaccine Pfizer vaccine is not whole spike. You have to remember that. They just have the RBD binding site small, not like the other vaccines that are whole spike. So they will have a very strong immunity only for that portion, interaction portion. So maybe that have something, but nevertheless, as you said, in the real world, this will work. In animal testing, in hamster people doing, or neutralization in vitro is a different scenario, but on the whole, they should work.
Okay.
Quite a bit, yeah.
Okay, so let me start taking questions quickly, and just to sort of, so that we can answer as many. I do urge you to be a little shorter and faster in responding, so everyone's gets their response. Ashok Mahadevan asks, and I'm coming to you, Professor Roy, why has the Indian government increased the interval for the first and second shot of AstraZeneca to 12 to 16 weeks, citing Britain's experience when the British government itself has reduced the interval from 8 to 12 weeks? So, I the question to you is not why is the government doing it, but how do you see this move?
Is it to me?
Yeah.
Oh, okay. Because for AstraZeneca's vaccine particularly, it appears because they have the adenovirus vector that cause some immunity as well against adenovirus, and that is causing some inflammation and some problems. So in order to cut down that, because if you come very quickly to boosting the vaccine, they will boost also adenovirus things. And to do that, they make it a longer gap. But generally, all vaccines that I work with, many vaccines in animal vaccine testing, and we generally always do, 21 days difference in between the booster and the challenge. But in this case, they wanted a longer gap because they realized that has to be cut down more. But on the other hand, they will also, antibody will go down, down, down before they can boost it again. So as far as I'm concerned, they have two reasons. One is because that reason, and secondly, because they didn't have enough vaccine.
Okay.
To make everybody first dose. So that's another reason.
Okay.
So
got it. Okay. Ganesh Natarajan asks, and Satchit, Dr. Balsari, I'm coming to you. He says, you and the panelists, you mentioned the rampant underreporting of cases and deaths. Is there a pattern that we could use as a correction factor to estimate the data reality?
Yeah, I think we can triangulate data. So what will not lie is excess mortality. In fact, a team that I was working with had done this in Puerto Rico a few years ago after Hurricane Maria, when the US government claimed that 54 people had died, and our team had shown that it was likely more than 4,000 people. There are several ways to do this. If you have reliable vital statistics data, death registration data, and this varies widely from district to district across India, that's one source of data. And you need to compare it to the last 4 to 5 years to get a sense of where it should have been this year, and you calculate excess mortality. That excess mortality will include deaths directly from COVID-19 infection, but also from COVID-19, the pandemic, from loss of access to medicines, to wages, to health insurance and whatnot, right? That's one source. The second pillar is, which will be the most reliable, is crematorium deaths. Someone needs to go count the dead bodies at the crematorium. The third is household-based surveys. You go to houses, which is what we've done in Maria. That's very cost inefficient, but you take a representative sample, you go to a whole bunch of randomly selected households in a particular geographic unit, and you ask them how many people died in the last 5 years, 4 years, 3 years, 2 years, 1 year, and this year, to get a sense then of what that excess mortality might be like. To answer your question, how do you correct? You correct by then triangulating. So you look at vital statistics data from a lot of places and then pick some sample areas and triangulate with these other sources to get some sense of what the error margins will be like. It's extremely complex, and I want the methodology to do this. Otherwise, we will end up with a sort of prediction models that we've had for the last 18 months around the world.
Okay. Dr. Satwik, let me come to you. Ram Ranjan Sharma asks, why is the Indian Council of Medical Research ignoring the cycle threshold or CT value as a clinical input?
Well, I can't answer on behalf of the ICMR.
Best guess.
Is that, well, my sense is that, look, all the testing data is going to ICMR, all right? All the data as regards hospitalization is going to NCDC. And all the data from sequencing is going to the consortium of 10 laboratories that are responsible for sequencing. What is astonishing is that even when we are on the subject of breakthrough infections, which would mean infections in a fully vaccinated individuals, the denominator for this should only be taken after the 7th of April, because that was the day on which the ICMR mandated vaccination status on the RT-PCR form. So those boxes were only introduced on the 7th of April. We have no data prior to the 7th of April if an infection happened in a vaccinated individual or someone who was unvaccinated. And this is considering our vaccination drive started on the 16th of January. So I mean, clearly we should be concentrating more on this because, as I said, this variant is going to travel. All that it takes is for one person with the variant to hop onto a flight and go to an area. Because, look, the critical part here is how many people are getting reinfected. If reinfection rates are very high, then the concept of disease-induced herd immunity has no meaning. Effectively, we're a clean slate after 6 months. We're exactly where we were in March of 2020. So we need data on breakthrough infections, on reinfections. This is going to help us construct a model for the future about what is going to happen, and also real-world effectiveness data on vaccines.
Okay. Professor Roy, here's a question for you. While the most plausible explanation does indeed appear to be that the virus was present at high levels even at the end of 2020, ground data to which I'm privy, rate of positivity supported by some seroprevalence data, and most importantly, hospital data, especially from areas of Bangalore and some districts of Andhra Pradesh, do suggest all this points to the importance of recognizing we may not really understand what is going on, especially on a pan-India basis. Professor Roy?
Oh, I thought I didn't realize it's me. So say it again. My mind was wondering something else.
Okay, so I think what he or she is asking is that, let me read that part again so that we get it clearly. While the most plausible explanation does indeed appear to be that the virus was present at high levels even at the end of 2020, ground data to which I am privy, rate of positivity supported by some seroprevalence data, and most importantly, hospital data, especially from areas of Bangalore and districts of Andhra, suggest otherwise. So what does this mean? What is really going on, or what was going on?
Listen, the virus, the first wave, did not disappear from India. I'm absolutely sure about that. It doesn't come from just something. They're circulating, even though it's apparently they suppressed, and because not all the data, I'm sorry to say, I'm sure that our doctor Delhi will not agree with me, but they are not transparent for everything. All the data, and I have seen some West Bengal data they sent me, which I did not believe in 2020, because I knew already how many people are getting infected, talking to just few families even. So virus is circulating, okay? Because it has to be. The social structure in India is such. They travel to each other, they're friendly, they're social, and there are pujas and all these other things going on. So the point is that virus is always good. And then a lot of those people, particularly India, have a younger generation people more asymptomatic, most likely. Even though circulating, there was no proper tracing, no proper testing going on there at all last year. So we did not know. And suddenly this burst come up, and the second wave, they said, and it was circulating. And young people started to get infected. And I was giving this interview in last week in Statesman. They said, oh, why the young people getting a lot of disease now? No, because it's getting more people getting infection. So you're noticing these young people getting disease. All question of virus load. If you have a high titer virus going in your body, you will show disease. And if you don't have high titer virus, low load virus, secondary infection going one to another, maybe less virus load, and then you're not going to show that much symptoms. So virus is going. The whole world and everywhere this virus is circulating, definitely, because people are still moving around everywhere. We already have now your virus in England now. We are absolutely done, nobody getting infection. Suddenly we get now 500 cases a day, which is absolutely surprising still. Probably they did not have any symptom, and they had no trace and no obligatory tracing and looking into it whether people have infected. And also other problem is that you have in India, a lot of things are costly. It's just not people not going to do that unless everything is free, given to all the people equality, absolutely equal way. Everything has to be, and that to come in India a long way. Equal system and equal opportunity for hospitalization, for the drugs, for vaccination is a long way yet. So it's not going to be that easy to disappear. Okay. So even though England without virus goes, we're going to get it again if India has it, because no way we can stop that. Too close now. The world is too small, So that's what I'm afraid of. So a lot of changes must be done in India to make it virus free, like all the other countries. Lots of things must be done. It has to be transparent. It has to be under somebody telling you, say that, not anymore. That's not the way to go forward, because this is not the way civilized world can, take the action. So we have to do that way, like everybody else is, every country doing that, trying to do that.
Okay. So, and I'm going to come back for third wave preparation question, with the third wave preparation question. So Vibha Krishnamurthy and Meher Padamji both ask, Vibha says, is there any actual evidence to suggest that the third wave will predominantly affect children? And Meher Padamji asks, why is the virus in Brazil attacking kids? And is it true that the third wave in India will be threatening for kids? Anyone who wants to respond to that?
No, I don't believe so. That's not categorically anything different. No.
So if I'm allowed to come in here.
Go ahead.
I've made the point earlier that what has happened is that we've basically locked up the kids for about a year and a half now. So they are in effect virgin soil and naive to the virus. So it's entirely possible that you'll get more infections amongst kids because they're the only ones that haven't been properly exposed to the virus. Whether it'll prove virulent in children is a completely separate matter. But about the third wave, what we do learn from the flu pandemic of 1918 is that it presented roughly about 2.5 to 3 waves. And we're dealing with a similar respiratory mucosal pathogen here. The first wave is a small wave. And this is immediately followed by mitigation measures and lockdowns and all kinds of non-pharmacological interventions to try and affect transmission. But obviously you get fatigue associated with these mitigation measures. And you have a large, and also there is selection pressure on the virus to mutate because you are doing, your measures are precisely preventing the virus from spreading. So all selection pressure would be on the virus to find more ways of transmitting itself and propagating itself. Add to that fatigue with mitigation measures and prevention, and you get a second wave, which is usually massive because you have a large vulnerable population, right? Now, once you're past that, the third wave, as it happened in the flu pandemic in 1918, was a sort of intermediate wave in terms of intensity between the first and the second wave, because again of mutation and fatigue, but you have a smaller vulnerable population that remains to be affected. The only thing that's different is because this time around, this is the first time in the history of humankind that we are actively vaccinating individuals in the middle of a pandemic, which is going to affect the trajectory of this pandemic.
Okay. So on vaccines, Vivek Jain asks, can vaccines be mixed, especially in view of shortages prevailing in India? Also, there is some confusion on the gap between the 2 doses. This has been constantly changing, which of course was posed earlier as well with reference to the British example. So it's open again.
Vaccine can be mixed, definitely. This vaccine, because there's all the vaccines that they made is targeting only one protein spike. It's not nothing else. And in fact, mixing and matching is better in a way. You get boosting about that particular protein only. The antibody made particular protein, not everything else is, not the vector. Because for adenovirus, say, for Russian vaccine, they use 2 different kind of adenovirus. The one that using as a vaccine for Johnson & Johnson and another one in Chinese company making, but they just mix match that for boosting and for priming. That's very good idea. And mixing something completely different way and delivery of the vaccine is even better. When I have been working with the vaccine a lot, different kind of vaccine, and I have shown that that is very important to do a different one. And Ebola vaccine that people made in Oxford and others also, different kind of way to make the vaccine delivery was better to mix matching, because then you don't have this interference of the delivery systems like adenovirus as a delivery vehicle. You don't have the interference at all. For instance, if you have a Pfizer and AstraZeneca chimp vaccine, chimp adenovirus vaccine mixed in, that's what they're trying now. I'm absolutely sure it will going to be safer and better boosting, most likely, because there is no interference from the delivery vehicle.
So you're saying that you're actually encouraging it. You're not saying that it should be a fallback option, but you're something.
No. Of course, biologically, it's very good.
It's if I'm allowed to come in here, I consider this to be sort of tripartite question about whether it can be mixed, whether it should be mixed, and whether we'll be allowed to mix it. Because the part, of course, it can be mixed. There's nothing wrong in mixing vaccines. Whether it should be mixed, well, there's some preliminary data coming in from some of the trials. It seems to suggest that the reactogenicity is slightly higher when you're mixing vaccines. What that means is that the vaccine producing a reaction in the body is slightly higher, but of course, there are also some evidence coming in that the immunity conferred might be better. But whether we'll be allowed to mix vaccines is a policy decision, and I don't see that happening in this country.
Okay, Dr. Balsari?
They're already trying, they're already doing in Oxford, they're already doing that completely. They're trying to do with the Pfizer plus chimp vaccine trial going on. And people are trying to see whether they can do like pseudovirals or protein-based vaccines completely and RNA-based. I think that RNA-based and protein-based is going to be different, but everything you see here, the way they're doing is probably, we're going to see it, what is happening. I mean, in England, they started already large scale. So we will know what happened. But my prediction is it's going to be better, boosting, definitely, because there will be no interference. And what do you mean by mixing? They're already mixing in Sputnik vaccine, they're mixing, and they showed the much higher level of antibody production and protection because they did two different type of adenovehicles for the adeno 26 and adeno 5 as a priming and boosting. That's because they changed completely the vehicle, so there will be no interference for the adenovirus immunity boosting. Is only the S protein will be the boosting antibody. So I thought they're very clever, the Russian group. Very clever. They have not done original anything other grouped up. They just mix match and using that. So that's fine.
Okay, Dr. Balsari, do you want to come in?
Concluding thought. We may not have the luxury of all these choices in India. I think we're going to be constrained by our cold chain and supply logistics too, right? So whatever it takes to get it out. I mean, some may be a little bit more efficacious than others, as we're finding, but they're all working so far. You know, there's been no alarming data of these not. I think India can ill afford sort of hand-wringing around this. You know, Pfizer, Moderna, cold chains are impractical for the majority of Indians currently. So whatever it takes to get it out to the last mile.
And, you know, so there's another question, or actually a couple of them relating to Covaxin, which in India you have Covishield and Covaxin. More people have got Covishield at this point. Covaxin is locally produced and manufactured. So what's your sense on that? So let me take the exact question. So it's anonymous. My question is that which vaccine is more effective? Is it Covaxin or Covishield? As I'm unsure because of insufficient trials or final results regarding Covaxin, and there are some suspected symptoms of thromboembolic events, like few cases regarding Covishield. What's your opinion regarding the efficacy?
Should I answer?
Answering their own question, right? They said that there's no data available, I think.
Covaxin?
There's just not enough data for any of this, right? I'll defer to Dr. Roy, but where is the information to answer this question?
Okay.
The Covaxin is just inactivated vaccine, which is standard vaccine that has been used for many vaccines before. So nothing fantastically new or anything. It's just the same procedure that we have used before. A killed vaccine, that's it. But only problem is the killed vaccine, it has all the other proteins, all kind of unnecessary protein the virus used for replication. They have that, all of that. So they have many things. So it's a pros and cons. They have all these other things. They may give some T-cell response, some other response, but there's lots of other things there, but easy to make, more or less. But problem of the Covishield, they have very few. They have this some effect, you see side effect, you know, whatever they have. Compared to the vaccine benefit, it is negligible. So to my knowledge and to my mind, I think both vaccines are fine in India to use. All these vaccines are fine to stop it. You get some effect, so what? You know, you get out from the severe disease, that's for sure. So I find both vaccines are fine to be used. Nothing wrong about that.
Okay, so I'm going to come back to the second wave, because I mean the subject for today's discussion is how to navigate the second wave. And while some of us living in Mumbai and Delhi may feel that things are easing off, in other parts of the country they're not, and maybe coupled with the fact that there's so much suppression of data that we're not even able to know unless it's in the most gory way what really is going on. So how do we, and there's a question from Dr. S.K. Pachauri as well. I mean, how will rural medical and health infrastructure be upgraded? And maybe I could supplement that by saying, what do we even do at this point? And let me begin with you, Dr. Balsari, and then Dr. Satwik.
A lot. I think we have a wonderful, wonderful army of community health workers. Treatment for the majority of people that will get infected with COVID is actually very simple. If we have protocolized treatment to do home-based monitoring, leveraging our community health workers, distributing, pulse oximeters instead of CADA, and having a very protocolized system to collect that information every day and act on it, we will take care of the majority of the patients. The small slice that needs to go to some kind of a clinical care facility that has oxygen delivery capacity must be envisioned with a process in place. Distributing thousands of oxygen concentrators is laudable. It will not have the desired clinical or population health impact unless closely tied to very simple protocolized checklist systems that ensure that people are getting the right kind of oxygen. We have to get down to the details. Is this a cylinder? Is this a concentrator? Is there electricity? Is this a nasal cannula? Is this a non-breather mask? If we sort of are disciplined about it, we can do this across India as well.
Okay. Dr. Satwik?
Right. I completely agree with what Dr. Balsari is saying, with the addendum that, I don't think we can ramp up infrastructure in a hurry. Last count, I think there were about 130,000 oxygen supplemented beds in this country in roughly 3,000 facilities. You can't suddenly increase and augment capacity in these terms. My sense is that I think you should be concentrating on blocking transmission, and messaging and education has a lot to do with this. It's not, let me tell you this. A lot of us have been working in COVID wards and ICUs. And the number of healthcare workers getting infected in COVID wards is, you can count them on the fingers of your hands in my institution. All the people, there have been numerous infections. All of them have been infected outside of the healthcare setting, in social spaces, in shared meals. So it's perfectly possible to protect yourself even if you're in the presence of someone with COVID. And I think education and literacy in these matters will go a long way. And I mentioned something about rapid antigen testing. In Delhi, at the peak of this wave, the turnaround time for an RT-PCR test was around 3 days. What use is that? All right. Now, we sort of hand-wavingly dismiss rapid antigen tests. What is a rapid antigen test? It's basically a paper test. It's a piece of paper. It's a lateral sorbent assay. And it's like a pregnancy test. You can get a result in 15 minutes. I'm positively evangelical about these tests because it's a self-administered test. You can get a result in 15 minutes. And it's extremely, extremely sensitive to pick up cases of COVID that are infectious. If you consider the entire sensitivity of these tests, it wouldn't be very much. It wouldn't even be 40%. But it's very sensitive in picking up cases that are transmitting infections. So if you have to get out of a pandemic, you have to pick a test and rapidly deploy it. In the US, they can be made available at $1 a test. With our scales, of economizing, we can go down. We can really start distributing this. The government should go really heavy on rapid antigen tests, because then you can do this on a 3 times a week basis, just to find out if you're infectious, stay confined and sequestered. If you test negative, you can step out. It will tell you if you're infectious on the day you're testing. That's a great accomplishment for any test.
Okay. And you've also answered a question Ram Ranjan Sharma asked, and about your view on the low sensitivity of RAT and allowing infected individuals to skip through. So anyway, so you've answered that. Let me come back as we head to a close. Siddhartha Srivastava says, and it's a longish question, but I think it's worthwhile because this is where we are today. Is the understanding that we are seeing a high plateau, and I'll come to you, Dr. Balsari, first. Is the understanding that we are seeing a high plateau with reference to the number of cases and early signs of a downward trend based on estimates gleaned from manipulated or incorrectly corrected data? If yes, then where do we stand in terms of diagnosing the actual peak or plateau? And two, how much of the plateau is attributable to the lockdowns across the country in the past 2-3 weeks? And what should we expect once the lockdowns are eased, as is being suggested by several states? And also, I guess, maybe looking back, what happened when the lockdowns were eased in August last year?
Lots of questions there. I'll try to answer a couple of them. Every exponential rise is going to be followed by an exponential dip, right? So this is natural. If we saw this like huge rise, of course, we'll suddenly also start seeing rapid recovery. I think trying to look at this as national numbers in toto is not advisable. We're talking about 1/6 of humanity with very different capacities, and also the pandemic travels right from region to region. There's urban-rural migration, there's other migration, there's cross-border migration. So I think we shouldn't fall into that trap. All this information is useful, the more it can be localized. Then you can combine it with what Dr. Satwik is talking about or what Dr. Roy said, right? Masking, rapid testing, local data to figure out when to calibrate, lockdowns and whatnot. So I'm not trying to dodge the question. I think the plateau may be real. It could also be a reflection of very poor data coming out of rural India, and we're clubbing all this together, right? So unclear. And this is the danger of us masking data rather than our faces. The second question was, do lockdowns work? Of course they work. I mean, you're thwarting transmission for a while, but what is the outcome you're measuring? If it is bringing down your R0 for the days in which you are in lockdown, yes, it does. Again, Dr. Satwik reminded us about the kids being in lockdown for a year. In toto, at the end of the year, if your morbidity and mortality are all sort of what they would have been or even worse, and you have impoverished populations, then lockdowns may not have been the right solution. So I think we might, at this point, at least 14, 15 months in, want to stay away from sort of a dogmatic one-size-fits-all solution. I think lockdowns are appropriate in certain cases, helpful when the numbers come down, because then you can have localized lockdowns. But in order to do that, you need the right data and the right testing infrastructure to quickly lock down a region or a community where you see some spread.
Okay. Right. So let's get a sum up from all of you. Professor Roy, let me start off with you. I think as we try and manage this, whether it's on a plateau or not, the second wave, and look forward to not hopefully at all a third wave. What should we be doing now at this point of time to ensure that we are better protected, better prepared, and to the extent we can, given our capacity, given our own track record in the way we respond particularly to public health crises like this one?
Well, the three things. One is, of course, test and track. Rapid testing is fine, right, that he already described. Second is still isolated as possible. Distance. That should be because it's aerosol. You have to remember it's aerosol, nothing else that's so important. Aerosol is most important. And third thing is vaccination. We have to vaccinate. More you vaccinate, better we are. And that's we are proving in England, definitely. Everything is opening, but we realize that vaccinated people, are safe. And that's what we have to do in the future. And India can make it. They have a lot of manufacturing capacity. If they want to really have everything they want to do it, they can do it. They can make all these vaccines and distribute. And government have to be very generous to everybody.
Okay, yeah, and that's an important point that you made. I mean, more equitable health infrastructure, but also a topic for another discussion. Dr. Satwik, your sum up.
Well,
as you look ahead?
Well, I think in valediction, the area under the curve doesn't change. This is probably an extension of what Dr. Balsari was saying, that what's going to happen when we unlock, well, that would depend on modeling based on the SIR model, the susceptible, the infected, and the recovered. It would entirely depend on the number of people susceptible and the how much the virus is going around in a community. What you obviously try and avoid is a very steep curve, because that's when you see carnage and mayhem, as we did in Delhi. You have to use that heavily bludgeoned cliche to flatten the curve. That's precisely what you have to do, because the area under the curve doesn't change. The total number of people infected will remain the same. You can flatten it out and spread it over months, or you can have a sudden peak in about 3 weeks. What is going to make the difference is vaccine-induced herd immunity. That's going to actually take a whole sizable fraction of people out of the susceptible set in the SIR model. Also, I think when it comes to modeling, and I think Gautam Menon made this point somewhere, that you mustn't be dependent on a single model or a super model as we did. I think there should be multiple models that you should keep referring to, and then perhaps in real time assess which model are you closely adhering to right now. And these should be open source models so that you know exactly where you're going and you can plan for the future.
Okay. And as a frontline medical professional dealing with patients, even if they may not be, they may be coming to you with problems other than the ones you can solve or resolve. What would you tell them? And including everyone who's here, who's either a potential patient or is connected with one.
Well, I'd say that the only way the virus can survive is inside of the human body. So you have to prevent yourself from getting infected. And I say this in all earnestness, it's not difficult. It's not difficult to stay protected, even when you're in the presence of someone with COVID, if you know what exactly is to be done. So the only way you can stop the chain, break the chain, is when you prevent yourself from getting infected. And it's not that difficult.
Okay. And on the subject of medicines and over-medication?
Well, you should always consult a physician, and I would urge members of my fraternity not to be cowboy physicians.
Okay. Dr. Balsari, last word.
Gosh, I've little to add to all this wisdom. I would build on the masking urge by saying that the community that is tuned in right now to an Asia Society conference has an opportunity to influence a whole pyramid of folks that are either employed by them or in their vicinity that are not tuning into an Asia Society conference. And if we can pay a little bit of attention to how all these families that are dependent on us or are engaged with us actually have the tools to mask up, not by distributing one mask per individual, but by ensuring that they are masked for a prolonged period of time until they get vaccination. I think at least as individuals, folks here have done their bit, right? I think it's sort of paying attention to the local context and recognizing how expensive it is to procure these masks, to maintain these masks, to recycle or keep buying new masks. They are a chunk of the salary for most Indians. That might be the best thing that viewers here can do immediately in their current environment.
Right. So we've run out of time. As someone who's on the, among other things, trying to fight the misinformation around COVID, it's obviously been a Herculean task. I think we have two kinds of perhaps information or misinformation. One is, of course, which is completely wild and is the kind which might tell you to take all kinds of alternate therapies and so on to cure yourself. And the other is when it's coming from qualified practitioners, it's even well-intentioned, but the outcomes are still not the same. So it's not misinformation, but it's definitely not the right information at the right time. So many things to resolve, and coupled with the fact that we do have a data crisis as well, apart from misinformation or an infodemic crisis, as the World Health Organization called it. So these are things to address and work upon as we are hopefully better prepared, at least better educated, if nothing else, for the next wave. On that note, Professor Polly Roy, Dr. Ambarish Satwik, and Dr. Satchit Balsari, thank you very much for joining in. My thanks to the Asia Society for inviting me to be part of this as well. Thank you and good night.